First of all, I think thank you very much for the very, very kind invitation to this AOS symposium. And today I would like to talk about kind of a novel therapeutic modalities for corneal endothelial dysfunction. My name is Shigeru Kinoshita from Kyoto, Japan. And once again, thank you very much, Dr. Titiao and Namrata Sharma for the kind invitation. This is my financial disclosures. Well, when we are thinking of the therapy for corneal endothelial failure, you may start from PKP, DSEC, or the DMEC. And in recent years, I think DSO has been, I would say, established or proposed. In addition to that, we may be able to make some of the eye drops, such as the low kinase inhibitor for corneal endothelial dysfunction at the early stage, and also some kind of injection of cultivated human corneal endothelial cells. So I'd like to talk this kind of a story for the following 10 minutes. Eye drops. We've been thinking that some of the eye drops, but low kinase inhibitor topical application may be the one such candidate. Nowadays, ripastidyl hydrochloride or netastidyl ophthalmic solutions are now available for the anti-glaucoma agent. In addition to that, Y27632, this is a chemical compound of the low kinase inhibitor, very potent for corneal endothelial cell proliferation and adhesion. These compounds may be applicable. So about 10 years ago, we started using the low kinase inhibitor eye drops treatment combined with a small endothelial removal via transcorneal freezing technique, 15 seconds. And that could remove some of the damaged endothelial cells, mainly targeting on corneal guttae area, and followed by the 10 millimolar lock inhibitor 6 times daily for 7 days. We published a couple of papers about 10 years ago. And then this is a 1 month post-treatment. Because this is the early stage of the Fuchs endothelial corneal dystrophy, that this patient can successfully obtain 20/20 vision about 1 month post-treatment. So the things has changed. Nowadays, the doctors try to use the DSO first and followed by the low kinase inhibitor eye drops. And this has been done for the clinical trial in the US as well. So I think that as long as the peripheral corneal endothelial cell is somewhat healthy, you may be able to see the beneficial effect of the low kinase inhibitor eye drops. However, decreased endothelial cell density in Fuchs endothelial corneal dystrophy or severe corneal guttae, these situations, we are not so sure about the low kinase inhibitor is effective or not. So we made a very brief review paper, I think published last year in the Journal of the Cornea by the Kathy Kobe and Friedrich Kruse. What about the cell injection therapy? We started from the very young donor allogenic cells, and nowadays we can create the cultured corneal endothelial cells for at least 300 patients, starting from just one donor cornea, and face down position for 3 hours. So this is just one example of the such kind of treatment. Buerer's keratopathy, a rather severe type of the Fuchs corneal endothelial dystrophy, and then inject the cells with a low kinase inhibitor into the anterior chamber, and the cornea become back to a normal. Cornea become transparent. When we culture the human corneal endothelial cells, they are heterogeneous. Sometimes normal mature differentiated corneal endothelial cells obtained, highlighted in blue, but not always. Sometimes culture cells show the cell state transition, such as fibrosis, EMT, senescence, or dedifferentiation. When you use the FACS analysis of the several cell surface markers, such as CD44, CD105 or so, the cultured cells highlighted in blue CD44 negative, CD105 negative. So these are normally differentiated culture cells. We are targeting these culture cells for cell injection. And we try to increase the proportion of these cells, the proportion we call the E ratio. If the E ratio is over the 90%, that would be ideal. I would like to show you a couple of minutes of video that is supplementary of the eye ophthalmology. Please take a look.
Procedure. Under local anesthesia, a device is used to create an 8 mm diameter circle. Corneal epithelium that is loosely attached at the central cornea is gently removed by mechanical rubbing to see the detailed posterior corneal surface. After making a 1.6 mm incision at the limbocorneal junction, the posterior corneal surface at the market central area is gently scraped by use of a silicone cannula irrigation needle in order to remove abnormal material on the Descemet's membrane. Note that the surgeon makes every effort to keep the Descemet's membrane intact and in its normal condition. Using an injection of a vision blur staining into the anterior chamber, scratched area at the posterior corneal surface is visually confirmed. Under a surgical microscope, the surgeon can examine the area in greater detail. After injection of block inhibitor solution into the anterior chamber for irrigation, the incision site is fixed with a 10-0 nylon suture, and the residual aqueous humor is extracted from the anterior chamber by use of a 30-gauge needle. A 26-gauge needle attached to a dead space-free syringe containing 300 microliter of solution with a 1 × 10⁶ cultured human corneal endothelial cells is gently and precisely inserted through the limbus. The entire solution is then slowly injected into the anterior chamber, thus completing the operation.
And then we ask the patient to have the face down position for 3 hours. We have performed the clinical research and clinical trials for the almost 10 years or so, divided into 5 groups. Group 1, 2, 3 are the kind of clinical research, mainly safety issues or efficacy testing or broadening of indicative diseases. And then after that, we have performed a phase 2 clinical trial and phase 3 clinical trial. And we finished these clinical trials, and now we have already submitted our final documents to a Japanese Ministry of Health and Welfare. So hopefully we will get approval from the Japanese government for this kind of products within a year or so. So in total, 65 cases performed. Group 1, 2 years data was published in New England Journal of Medicine, and 5 years data is published in ophthalmology last year. And then we compared these two, group 1 and group 2. What's the difference? That difference is an E ratio. E ratio is under 76% is group 1. Group 2 is over the 90%. Very mature cultured endothelial cells. These data was published this year in AJO. So this is the initial 11 cases of the cell injection therapy. All these cornea become transparent and the corneal thickness come down, visual acuity improved around 4 weeks after the cell injection therapy. And the 5-year results of the average of the corneal endothelial cell density is about 1,200 cells per square millimeter or so in group 1. So this data is almost the same as the DSEC or the DMEC procedure and published elsewhere. And then this is interesting. We compared group 1 and group 2. Cultured endothelial cells density is almost the same at culture flask, but FACS analysis shows that some difference. Group 2 shows more mature differentiated endothelial cells. And then when we inject cells into the anterior chamber, amount is the same, 1 times 10 to the 6th. Both are the 1 times 10 to the 6th. But for instance, 4 weeks after the cell injection, the group 2 showed a rapid, I would say, corneal transparency, corneal restoration occurred. More interestingly, this data, 3 years post-operative, Group 2 did show the cultured corneal endothelial cell density that is over the 3,000 cells square millimeter or so. And also there's not much of the decay of the endothelial cells as compared to Group 1. So after cell injection, using the Group 2 type cultured endothelial cells, in terms of the corneal endothelial cell density, this is more like a cataract surgery. And there's not much of the decrease of the endothelial cells. So this technique can be used in a graft failure after the penetrating keratoplasty as well. The cornea become quite transparent, just inject the cells into the anterior chamber by scratching on the descemet membrane. A presumed advantage is a minimal immunological reaction. We haven't seen any immunological reaction. There's some of the theory which we have. A normal corneal configuration, and then most importantly, cornea endothelial cells become rejuvenated endothelial cells. So once again, so this is a kind of a future therapy for corneal endothelial failure. Eye drops and then a cell injection. At least these two types of the procedure can be applicable for the future treatment of the corneal endothelial failure. Thank you very much for your very kind attention.
Thank you, Dr. Kinoshita. It was a wonderful lecture, and it is really exciting to see that endothelial cell culture is going to revive the disease endothelium from patient. And the audience here is totally spellbound with your lecture. We have panelists, if they have any questions which can be answered by Dr. Kinoshita.
Yeah.
I just had a question, Dr. Kinoshita.
Yeah.
When do you think,
Yes.
true in fact, when do you think this will be commercially available, maybe in your country and then in ours?
Yeah, I think at least in Japan, I would say about in a year or so, I think we are supposed to have official approval to use this cell product from the Japanese government. I hope. Then after that, it's very slow, but within a few years, I think you may be able to use that. This kind of thing.
Thank you so much, Dr. Kinoshita.
I think we would like to have a comment from Dr. Jodh also, because you have experience, you have done a lot of work in this area.
Yeah, I mean, like Shiguru says, I mean, it's an opportunity to really change the way we perform endothelial surgery. With all these cell therapy trials, the biggest limitation is going to be cost. To develop the facility and get past the regulations for each individual country, which will be the hurdles. Unfortunately, most countries will not necessarily accept regulatory approval from another authority, even from FDA or EMA. And these are some of the challenges that will limit the widespread dissemination of the technology. But I think it's exciting, really future for our field.
Okay.
Yeah, I think Jod is quite correct. I think money issues as also the problem. And we could actually produce the cultural cells for 1,000 patients starting from just one donor cornea. So I think technology is coming. And the other thing is how to solve the financial things.
Thank you very much. We welcome Dr. Bishal Janji also. Good morning, Bishal.
Good morning, Dr. Tiam.
Yeah.
How are you?
We are fine. Just one more query, Dr. Kinoshita. In your series of cases, was there any chance in some cases you had to repeat the injections? Or it is a one-time injection only?
No. I think that's of course we can do that. We can do that. I think it's just a matter of the how the government will decide just to sell one injection or maybe we can do a couple of them or 3 times or so. I think technically, scientifically, we can do the I think repeated injection.
Then there's another question. If you repeat, is it from the same donor or from a different donor?
Well, I think a different donor.
Okay.
Yeah. Cell suspension, allogenic cells, cell suspension, when you inject into the anterior chamber, there's no antigen recognition occur. So I think that even though they're different, the donor and corneal endothelial cells, I think probably they do not show endothelial rejection.
Okay. Thank you so much. Thank you, Dr. Kinoshita. I request Dr. Rajiv to please invite the next speaker.
We have Dr. Jodhbir Mehta from Singapore, and he's going to give his keynote address on non-cultured endothelial cell therapy. Dr. Mehta, please.